Hello. Hello. What? It sounds on my side. Did you hear it from my side? I don't know why there's no sound. I'm literally. No, I'm not. I need to be unmuted so that they can hear the sound. Should I replay it? Okay.
Sam,
Hello, Charles.
we didn't get any sound.
Oh, sorry. Let me try that again. Just bear with me
Yeah.
1 second.
Okay. All right.
Is there sound now? London? No sound.
Still no sound on this end.
Okay, 1 second. Hold on.
These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, ladies and gentlemen, and welcome to the Caribbean African Targeted Health Improvement Program, CATHIP. CATHIP is a program that's been running, originally started in May 2020, but then, in the last year, we've had 5 other partners join. So it's now being delivered as, a 6-organization partnership. And the other partners, in addition to the Caribbean African Health Network, is RAFA, International Development Agency that is based in Birmingham but works across the country. Please, could I ask people to mute themselves if you're not speaking? Right, so we've got RAFA, International Development Agency, that is based in Birmingham but works across the country. We've got Croydon BME Forum based in Croydon, Enfield Caribbean Association that's based in Enfield, Black Health Initiative based in Leeds, and then the RCCG, church in Sheffield. This morning, we're delighted to be joined by Dr. Edmond Edi-Osagie, who is no stranger, but really well known. He's a specialist in his own field, and he is no stranger and has been on this show a couple of times. This morning's topic is all about fertility. And he's going to be looking at a number of health conditions or issues that could get in the way of fertility. Many of you will know 8th of March is International Women's Day. So the whole of March, we're going to dedicate it to women's health. And we're kicking off with today on fertility. Next week, we're going to focus on the menopause. And then the week after, we're going to look at the impact of domestic violence on women's mental health and well-being. And then we will run it off, the following week with another female-related topic. So without taking much time, pleasure is mine, and most of you will know, him, or you know his wife, who has been hosting sessions after sessions. So Dr. Edi, massive thanks for your time once again, and over to you.
Thank you. Thank you very much, Charles, for that kind invitation. And thank you, CAHN, for inviting me back. It's been great. It's always great to be on this forum. And as I always say, impacting knowledge and education is something that is very, very important to me. And I think what this health hour does is excellent for people from our community. And I think it's especially relevant that we are responding to this Women's Health Awareness Month, and using that to impact knowledge about relevant issues regarding women's health care. So today, CAHN has asked me to talk about subfertility, but not just subfertility on its own, but also to talk about some of the surgical issues that can impact on fertility. So just as an introduction, I will, for those who don't know me, I am a consultant gynecologist. I am a specialist in reproductive medicine and surgery. So my areas of expertise include all aspects of fertility, including assisted conception and also advanced laparoscopic surgery. And I currently practice at the Alexandra Hospital in Chido. So if we start from this amazing human body that we have, and whatever anyone believes in, the human body is just an amazing machine. If you look at this picture, all the different parts of the body have been designed in such a way that they work very effectively most times, and they interact with all the other parts of the human body. And it's really important that we learn about the functioning of the body, because that helps us to understand when things are not going right. And that's the beginning of trying to fix those issues. So I will start from the very, very basics, and we'll just talk about how the female body functions. And to be able to do that, I think we need to understand the phases of female life. So for any woman, it's a journey from when they're born up to when they eventually die. And there are different really important phases that have a profound impact on how their bodies function and how they're able to fulfill that very basic of functions called reproduction. So a lot of people might not know that when a woman is born, she's actually born with all the eggs she's going to have throughout her life. So some estimates reckon that women form about 7 million eggs when they are still developing in their mother's wombs. But by the time they are born, on average, those eggs have declined to about 2 million. So women are born with an average of about 2 million eggs. And then when they get to the age of puberty, which is probably about on average around the age of 12 to 13 years, that egg count has diminished significantly to only about 500,000. And between birth and puberty, there's a lot of physical growth. And when they get to puberty, there are a lot of profound hormonal changes that start to determine what will happen in the next phase, which are the reproductive years. And this is where women go through pregnancy, childbearing, and in that period, they go through cycles where they release these eggs until they get to a stage where all the eggs are exhausted from their ovaries, and that's when the menopause sets in. So this basic understanding will help us to appreciate how the female body functions. So the three areas we're going to look at today are infertility, fertility and infertility, and then we're going to look at two conditions that can impact profoundly on that, fibroids and endometriosis. And the one key thing that holds all of these three conditions together is a hormone called estrogen. So estrogen is a female hormone, is a basic female hormone really, that's responsible for the growth and development of female reproductive organs, including the breast, the development of both the external and internal genital organs. And there is a profound and very coordinated sequence of events all the way from the brain down to the ovaries, down to the womb itself, that coordinates this development. And because of this hormone, women go through what we call a menstrual cycle. So the way a menstrual cycle is designed, you'll see from this main picture in this diagram, after a woman has a period, there is a development of eggs in her ovaries. So eggs are selected, are recruited, and they start to grow. And as they grow, they release this hormone called estrogen, which influences the lining of the womb to develop in readiness for pregnancy. And about the middle of the cycle, the egg is developed enough to be released, and that's a process called ovulation. And this is a point where if the woman engages in intercourse, that egg can be fertilized and by sperm, and if it implants into the womb, a pregnancy results. But for that implantation to take place, after ovulation, a second hormone called progesterone has to be developed. And this progesterone alters that lining of the female womb in readiness for pregnancy. So if the egg is fertilized at that stage, it can implant into that transformed endometrium and a pregnancy ensues. If a pregnancy doesn't ensue, then those hormones fall back down to lower levels and the lining of the womb is shared again as a menstrual period. And this cycle goes on month after month after month until it is broken by pregnancy or some other external factors. And we generally advise that the duration of the menstrual periods should normally be between 2 and 7 days. And the duration of a menstrual cycle should normally be between 21 and 35 days. And anything outside of that, then women should start to ask the question if there's something wrong and maybe seek advice. And I like this cartoon, but it contains a lot of facts about what really happens and how pregnancy comes about. So from the brain stimulates the ovaries to generate eggs. The ovaries release the eggs, which pass through the tubes. And then after intercourse, sperm passes through the genital tract, through the tubes to meet those eggs, fertilizes the eggs, and then the eggs end up traveling down the tubes back into the womb, as you can see here. And so for pregnancy to happen, all of those things have to be working well. So you need to have a male who produces a decent amount of sperm. You need to have a female who produces eggs every month. And then you need to have the passage. So that's the communication between where the eggs are released from the ovaries and the sperm for fertilization to take place, and then for that fertilized egg to travel back into the womb and be implanted. And just to share some statistics with you, for any couple that's having intercourse in a month, the chance of achieving a pregnancy in any 1 month is actually quite small. It's only about 25%. And over a year, that builds up to an average fertility of about 85%. So if you take an average couple having unprotected intercourse, after a year, we expect that out of 100 couples doing that, 85% of them will get pregnant, which means that on average, 15% will not. And within that 15%, it could be that there are issues or factors preventing pregnancy and that they might need some help to overcome those issues. So there are some things that we know that can impact on fertility. And the most profound one is age. So the younger you are, the better your fertility. And if we look at it from the female angle, the younger a female is, the younger her eggs are. If you recall, I told you at the beginning that women do not produce new eggs in life. All the eggs they have are eggs that were deposited in their ovaries when they were growing in their mother's wombs. So as the woman ages, those eggs age as well, and their quantity is depleted. So age is a really important factor for fertility. The other thing that a lot of people probably don't appreciate is coital frequency. So the number of times you're able to engage in intercourse can have a profound impact on your ability to conceive. So I know a lot of people practice what is termed as timed intercourse, where they try and determine when a woman ovulates, and they try and concentrate intercourse around when a woman ovulates. Studies show that that's actually not the best way to achieve conception, and that people who have regular intercourse all the time actually have a better chance of conception. Excessive alcohol intake can be detrimental to fertility, both for the male and female. Smoking can be detrimental to fertility, both for the male and female. And to optimize fertility, we recommend that people keep their body weights within normal limits so that their body mass indices are in the recommended range between 19 and 29. So caffeine, as you find in coffee and some of these energy drinks, excessive intake of that can be detrimental to conception. We know that from studies in women who are undergoing IVF treatment. And there are some drugs that can also impact negatively on conception. So we do recommend that for people try and avoid unnecessary drug use when you're trying to conceive. So this graph just represents the impact of age. As I said at the beginning, age probably is the most important, the most critical factor when it comes to fertility. And you can see that as a woman's age increases, her fertility declines significantly. And past the age of about 32, that decline becomes more profound. And again, after the age of maybe about 38, there's a significant decline in fertility. So what that's saying is people who are considering getting pregnant should be thinking about starting that early, if that's feasible, and if not, considering other options that might be available to them, including things like maybe freezing eggs. We'll come to that towards the end. So what are the things that can interfere with fertility? So this slide shows that there are 4 main categories of problems that can interfere with fertility. So on the male side, anything that alters sperm production can interfere with fertility. So low sperm count, poor movement of the sperm, abnormal shape of the sperm, and sometimes when there is no sperm production at all. And on the female side, anything that interferes with ovulation, either where ovulation doesn't occur at all or where ovulation is inconsistent, can interfere with fertility. And as women get older, unfortunately, the quality of the eggs they produce also diminishes, and that can also interfere with fertility. So we talked about the passage. We talked about the passage that is important for the passage to be patent. So the passage from the tube into the uterus, into the vagina. So anything that interferes with that passage causes blockage, something like such as a tubal block, can interfere with fertility. And the other issues, some of which we'll talk about, are problems like fibroids, endometriosis, and other acquired issues. So in terms of how common these problems are, in about 1 in 4 couples who have difficulty conceiving, we don't actually get to the bottom of why they have those difficulties. So after investigations, we might not find a cause for the difficulty in conceiving. And we class those as having what we call unexplained infertility. About a quarter of couples experience ovulatory problems where the woman is not ovulating regularly. In about 1 in 5 couples, there are problems with tubal blockage. About a third of couples have issues to do with poor sperm parameters. And then in 1 in 10 couples, there are uterine or peritoneal factors, including endometriosis and uterine fibroids. So it's really important to stress that most of these issues that we've talked about are treatable. So we have got medical treatments that we can apply that can overcome the vast majority of these problems that we have enumerated. And for the surgical problems we've also highlighted, there are treatments available both by laparoscopic and hysteroscopic surgery. So most of these problems are treatable. So we'll come back to the treatments later on. What I'll just like to do is go back to talk very briefly about endometriosis and uterine fibroids, and then we can wrap up with treatment for all the conditions, including infertility. So endometriosis is actually a condition that a lot of people do not know about, but causes a profound impact on women's health. It can be a significant cause of pain and morbidity. And it is common. 1 in 10 women have endometriosis. So if you try and extrapolate to women all over the world, they reckon about 176 million women worldwide have endometriosis. And because a lot of people do not know about this condition, it can take quite some time for it to be diagnosed. Some women who have endometriosis, up to a quarter of women who have endometriosis, do not have any symptoms at all. So sometimes they will suffer for the condition will carry on progressing and cause significant impacts and damage, including subfertility, with the woman not being aware at all that they've got the condition. So what is endometriosis? In the past, we used to think that endometriosis was a pelvic disease that caused lesions in the pelvis and was a local pelvic disease. But we now know from increasing awareness and studies we've done that endometriosis is actually a systemic condition. So it's now considered a systemic chronic inflammatory condition that has specific local manifestations, like in the pelvis, where it causes lesions to be deposited on the pelvic organs and the pelvic wall. So endometriosis is where we find tissue that is normally only found in the lining of the womb, in other places outside the lining of the womb. And these tissues undergo cyclical chronic inflammatory changes as the cycle progresses. And that chronic inflammation gives rise to pain and all the other manifestations of endometriosis. So the way to think about endometriosis is the lining of the womb that women share during a period, for some reason, is now found outside of the lining of the womb on the pelvic organs, especially the pelvic lining. So this picture depicts that really well. So this is the womb here, and the lining of the womb should only be found in this region here. But in women who have endometriosis, you can see all of these red areas represent areas where endometriosis is typically found. So this is a picture of 2 pelvises. The one on the left is a healthy pelvis, and you can see how you can see all the structures. Everything is separate, everything looks healthy. And the picture on the right is a picture of a woman with endometriosis. You can see how the pelvis looks inflamed. There's a lot of tissue stuck together. The fallopian tube on the right side appears blocked and buried. The ovary and the fallopian tube are stuck to the womb. So these are a typical picture of what endometriosis causes and how it can distort anatomy. We don't know for certain what causes endometriosis. There are a number of theories. What is becoming clear is that endometriosis has a genetic basis. So we think that women inherit a certain gene that predisposes them to developing endometriosis. And those women, when they get to the age of puberty and they start to produce estrogens, that influences how endometriosis, the development of endometriosis in those women. So we think that gene alters the immunity in those women and allows endometriotic tissues to develop. So endometriosis causes a number of problems in women, the most profound being pain. So the one thing we say is, it is not normal to have menstrual pain that stops you from going about your normal activities. So any woman whose periods are so painful that they are unable to go to work or unable to go to school, that's not normal period pain. They should be asking themselves whether they have endometriosis and seeking help. So period pain, non-cyclical pain, pain in other at other times of the cycle, again, that can be due to endometriosis. Endometriosis can cause significant pain with intercourse. And again, any woman who finds that they can't engage in intercourse because of pain should be wondering whether they got endometriosis and doing something about it. Endometriosis can cause menstrual dysfunction by way of heavy, prolonged, and very painful periods. Fatigue, extreme tiredness is one of the things that a lot of women with endometriosis complain about. And all of these things can contribute to causing a significant impairment in their quality of life. And we've already mentioned infertility in women with endometriosis. So what we know now is that endometriosis is not just one condition, but that endometriosis, there are different types of endometriosis, and those different types can have different impacts on women and different manifestations. So the most common type is the peritoneal endometriosis, where lesions grow on the pelvic wall lining, and that can give rise to significant pain. And then you have ovarian endometriosis, where cysts develop in the ovaries that eventually grow to contain chocolate material. And then there's the deeply infiltrating endometriosis, and that's the one that grows in tissues. So you have these that will develop in the rectovaginal septum, for instance, and they can grow into the bowel, they can go into the bladder, they can go into the ureters. And then you have endometriosis that affects the womb, that's called adenomyosis, and the so-called extragenital endometriosis. And I think I've got some pictures just to illustrate these. So on the left here, you have got peritoneal endometriosis, where it's just on the lining of the pelvis. On the right, you have got ovarian endometriosis. And then you've got the rectovaginal disease that grows deep into the tissues. And this can be profoundly impacting on intercourse. So this is endometriosis outside of the pelvis, and you can have endometriosis affecting the belly button, and this will typically cause bleeding from the belly button during periods. We found endometriosis in episiotomy scars, where women just find them really, really painful and they interfere with intercourse during periods. We found endometriosis in operation scars. This is a cesarean section scar. So every time a woman is on a period, this grows, becomes painful, and sometimes will bleed. All these are due to endometriosis. And then we'll have the so-called extragenital endometriosis that affects tissues. Virtually any tissue in the body can be affected by endometriosis. We found endometriosis in the brain. This is endometriosis in the lungs, and it can cause typical cyclic symptoms. So if the symptoms that a woman experiences are only occur during periods, and they are to do with inflammation, then there is a chance that endometriosis is involved in those symptoms. And we know endometriosis is associated with a lot of other conditions, irritable bowel syndrome, in 50% of women with endometriosis, migraine headaches, inflammation of the bladder, fibromyalgia, and eating disorders. So endometriosis causes a lot of problems, but regarding fertility, how does it impact fertility? So we already mentioned that endometriosis can interfere with sex because sex becomes too painful and people are just unable to engage in it. Endometriosis can interfere with the egg and sperm coming together, which needs to happen for fertility to occur by causing tubal blockage. Endometriosis can also interfere with the sperm being able to penetrate the egg, again, which needs to happen for fertilization to take place. Endometriosis can cause poor endometrial development, which impacts on implantation, and that interferes with pregnancy. And we now know that endometriosis increases the risk of miscarriage. So even when you do conceive, if you have endometriosis, there's a higher chance that that pregnancy will not continue. And endometriosis, particularly the type that involves the ovaries, can cause damage to the eggs in the ovaries, and that can diminish a woman's ovarian reserve and impact fertility and lead to early menopause. One of the biggest problems with endometriosis is the delay in diagnosis. So again, it's important for women who experience significant cyclical or non-cyclical pelvic pain to seek help to find out whether they've got endometriosis, because the earlier it's picked up and treated, the better the outcomes. And the diagnosis is by examination, ultrasound scan, and ultimately laparoscopy. Endometriosis can be treated very effectively. So by surgery, we can excise all the lesions of endometriosis. And we know that by excising the lesions of endometriosis, we can improve fertility in women. So they are very effective treatments for endometriosis. Okay, I'll just touch briefly on fibroids, and then we'll round up with the other treatments of infertility. So what are fibroids? So fibroids are benign tumors arising from the uterus, arising from the smooth muscle and fibrous tissue in the uterus. So the way I like to describe fibroids is everybody knows about benign breast lumps, and I tell women to think about fibroids as the womb's equivalent of benign breast lumps. So these are just lumps that grow in the womb from smooth muscle. They are benign, and they very rarely undergo cancerous change. They are very common, especially within the Afro-Caribbean population. They affect up to 50% of women at some stage in life. The vast majority of women who have fibroids do not even know they have them. They are symptomless, and a lot of the time we pick them up when we do scans for other causes. And the most significant problem they cause is menstrual dysfunction. So again, if a woman has very heavy periods, then you should start to ask the question, do I have fibroids? And get checked out. So although we do not know how common it is, we know it's very common. And we think about up to 50% of women over the age of 30 have fibroids. We know it's commoner in women of Afro-Caribbean origin, and we know the prevalence increases with age. So how do fibroids impact on fertility? Again, they can interfere with sexual exposure. Sometimes fibroids are located in areas where they can cause significant pain during intercourse, and because of that, people just avoid intercourse. They can interfere with access to the ovaries for things like egg retrieval for fertility. They can interfere with implantation if they're big enough to alter the lining of the womb. They also can increase the risk of miscarriage if they alter the lining of the womb. And the closer the fibroids are to the lining of the womb, the greater the impact they have. And although there's no size of fibroid that we will class as significant, generally we consider that fibroids that are over 5 centimeters in size are significant. So again, fibroids, we pick them up by examination, ultrasound scans, sometimes MRI scans, and they are very effective treatments for fibroids. mostly surgical, so we can do laparoscopic or hysteroscopic surgery to remove fibroids, or sometimes we have to do open myomectomies to remove them. And generally, removing the fibroids will remove the negative impact they have on fertility. Okay, so just coming back to round up with the treatments that are available for subfertility. And again, it's important that people know that no matter what the cause of the subfertility is, there are ways that we can help couples to overcome those problems, from inducing ovulation to intrauterine insemination, ultimately to IVF. So helping yourself, how can couples help themselves? And I think this is really important. We talked about age. The younger a woman is, the better the chance of pregnancy. So for people who do not have the opportunity to start trying to conceive, and they feel they're getting older, there are options they can consider, like egg freezing, which is now widely available. Coital frequency, we recommend that when people are trying to conceive, they have regular intercourse 2 or 3 times weekly rather than timed intercourse. Minimizing alcohol intake, stopping smoking, maintaining body weight in the ideal range would help to improve fertility. Similarly, minimizing caffeine intake and avoiding non-prescription medication. And I reiterate again, seeking help early is really, really important. We provide counseling because we know that subfertility can be an emotional roller coaster for people, and sometimes people feel like their life is on hold until they actually are able to achieve their desire of a pregnancy. They feel isolated, it puts strains on relationships, and we've heard stories of relationship breaks down because of subfertility. So these are things that we can help couples deal with by counseling. Nutrition is really important. What you take in can have a profound impact on your fertility. So when people are trying to conceive, it's really important that they think about nutritional intake, maintaining a balanced diet with vitamins and supplements. As you know, it's recommended for anybody trying to conceive now that they must be on folic acid and vitamin D supplements. And we recommend that every woman trying to conceive should also be taking a multivitamin preparation. Most of the common pregnancy multivitamins like PregnaCare will contain a good dose of all of these. Maintaining regular exercise, keeping your weight in a normal range, managing alcohol, caffeine intake, which you already mentioned. So the way to think about fertility generally is the healthier you are, the better your chance of getting pregnant and getting a successful outcome out of that pregnancy. Where all those do not help, there's help available with fertility treatments. And I'll just highlight IVF. IVF is safe. IVF is widely available. Unfortunately, there's people who have a lot of fears about, unfounded fears about IVF, but they're very, very safe. And it's a treatment that's given to us to help couples in this position. So please tap into it if you do need to. Your doctor will be able to advise you if that's the best treatment for you. Okay, and we'll just finish with this, just to reiterate that IVF is successful. If you remember at the beginning, I showed you the chance of a couple trying to conceive, achieving pregnancy in any one cycle, and I told you it was about 25%. These are the results we get with IVF in our center. So we achieve pregnancy, ongoing pregnancy rates of about 47% with IVF or ICSI, and similar pregnancy rates with the frozen embryo transfers. And where we're using donor gametes, like donor eggs, we're achieving ongoing pregnancy rates of about 55%. So those are really, really good rates of return. So I will stress, to finish this talk, that subfertility is treatable. It breaks my heart when I see people who come to see me after maybe about 15, 20 years of struggling with subfertility on their own. And unfortunately, at the time they come to see me, it's sometimes too late to do anything because the woman's ovarian reserve is very low, or she's even menopausal. So I reiterate, seek help early. Help is available, and a lot of the help we render is effective. Thank you very much. And I'll stop there for now, and I'll be happy to take questions.
Great. Thank you very much, Dr. Edi-Osagie, for such an insightful presentation. And I believe we have various questions, for you. And I know, Doc, you talked about age being a key factor. So what would you say? I mean, what range would you advise?
If people do not take anything away from this talk, if the only thing they take away is age, then I'm happy that they take that away. Age is so crucial. And the reason it's crucial is because of what I said at the beginning. Women do not form any new eggs in life. So once a woman is born, she has got all the eggs that she's going to use throughout her life. And from the time of birth, all of those eggs are depleted. So on average, we think that women are born with about 2 million eggs. But by the time they get to the age of puberty, at about 12, 13, that egg count has declined to 500,000. So women have only 500,000 eggs that they're going to use throughout their reproductive life. And what happens is during your reproductive cycle, so each menstrual cycle women go through, their bodies recruit a certain number of eggs from their egg pool. So it could be 10, it could be 20, it could be 30, it could be 50. And from this number, the woman allows only one egg to grow to the point where it's ovulated and the rest die away. And that's how month after month after month, all the eggs in the egg pool are depleted. So if you think about starting at the age of 12 with maybe 500,000 eggs, and you're depleting maybe 50 every month, by the time you get to the age of 30, you can imagine the amount of diminution that has occurred with your egg pool. And that's how, it declines. And what we also know is not every egg in your egg pool is a healthy egg. So there are some eggs that are genetically abnormal. There are some eggs that are morphologically abnormal. And I like to describe this with the analogy of a 100-meter race. If you go into the streets now and take the next 1,000 people you see and say, come and do a 100-meter race, the people who are going to be at the front of that race are the young, the healthy, the strong. And then you find people who are not so strong, not so healthy towards the back of the queue. So what we know, what we think, we've not been able to prove this because it's impossible to prove, is that when women start to use up their eggs after puberty, they tend to use up a lot more of their healthier eggs initially. And then as they get older, the proportion of unhealthy eggs, the proportion of genetically abnormal eggs all increase. So, and this is why as women get older, the chance of getting pregnant decreases and the risk of miscarriage increases. So for instance, if you take a woman at about the age of 30 and say her chance of getting pregnant is 85% in a year, her risk of miscarriage is about 15%. A woman at the age of 40, her chance of getting pregnant will probably be about 50% in a year, and her risk of miscarriage will be about 50% as well. That means for every pregnancy that that woman conceives, half are unlikely to undergo miscarriage. And we think all that is happening because of the increased proportion of genetically and morphologically abnormal eggs. So that's why age is critical. So the younger these things happen, the better the chance of there being healthier eggs that can be utilized for the pregnancy. And so that's why we make the point that for people who are not in a position to start trying to conceive, we've advanced medically to be able to provide services like egg freezing, which people should consider. Once the eggs are taken, so if you take a 30-year-old's eggs and freeze them, they remain at that stage of being 30 years old, even if they're frozen for 50 years. So that's the beauty of egg freezing.
Great. Thanks very much for that, Dr. Edi-Osagie. Right. So for those who have just joined, we're focusing on fertility, and Dr. Edi has done his presentation. He's taking questions now. I know some of you are happy to post your questions for everyone to see. Others may want to send it privately. Feel free to send it privately to myself or any of the co-hosts, but we field in them to Dr. Edi. So, feel free to send us the questions. So, Doc, building on the discussion around freezing eggs, and you are really reassuring us. And also, for all those who have joined us, just to say, many people across Greater Manchester and beyond know Dr. Edi-Osagie. They know what he's done. He's helped, so many people. So he's well seasoned. One private question is, my daughter has just turned 18 and had the shortage of black eggs, and she wants to donate. The mother is concerned and, is thinking she's really young. But, the fact that the advertisement said she could get £700, for the donation, that incentive seems to be attracting her. What support or advice, would you give to the mother who seems to be concerned, to have an informed discussion with, her young 18-year-old?
That's a really, really good question, Charles. And I thank that mother for this question. It helps me to delve into the issue of egg donation, which is another huge area that I really want us as the Afro-Caribbean community to consider. And I'll start with that, and then I'll round up with answering her question directly. Egg donation is a huge area. There certain medical conditions mean that we'll have to take women's ovaries out, so they will lose their eggs, either because of endometriosis or because of cancer. And sometimes, as we've heard in my presentation, women go through an early menopause. We have 25-year-olds, 30-year-olds, 35-year-olds who come to our clinics with early menopause, meaning they have no eggs left. And for those women, the only way we can help them is by egg donation. Egg donation means a younger person with a healthy ovarian reserve would donate eggs that will utilize in an IVF cycle for the woman who doesn't have eggs. And people might not know that egg and sperm donation are so common now in the UK that 2% of all the babies that are born in the UK now are from gamete donation, either egg, sperm, or embryo donation. So that's how common it is. So it is mainstream. We have a particular need for egg donation in the Afro-Caribbean society population. If you take the last year we have records for, where we had nearly 2,000 egg donations in the UK, just think, how many of those do you think came from Afro-Caribbean women? Only 20 of nearly 2,000 egg donations in the whole of the UK. So we have Afro-Caribbean women, the length and breadth of this country, who are desperate for eggs, but just have no way of getting these eggs. So we are pleading with women from the Afro-Caribbean community who want to consider egg donation. There is a real need for it. There are lots of women who are desperate to receive eggs. And if you're healthy, if you're under the age of 35, then you are eligible to donate eggs. And if anybody is interested, please direct message me and I'll send you some information to consider and we can go through the process. Now, to answer that mother's question directly, her 18-year-old daughter is an adult, so she can make her decisions. But one of the things we do consider when we are screening potential egg donors is we like them to be a bit older to understand the implications of their egg donation. So typically in my clinic, we will not recruit anybody who's under the age of 20 for egg donation. But any adult, female, who's under the age of 35 by law can donate their eggs. What we do for anybody who wants to donate is We offer them what we call implications counseling. So we have a senior fertility counselor that sits down with them, talks through the process with them, tells them what the law is, makes sure they understand the implications of egg donation. So the one thing I want to say is egg donation is safe in terms of medically safe to the person donating the eggs. So you are extremely unlikely to come to any harm from the process of egg donation. The other thing I would like to say is we do not deplete a woman's ovarian reserve through egg donation. If you recall, when I made my presentation, I said every month a woman recruits a certain number of eggs from her ovaries. And from that number she recruits, she allows one to develop to the stage where it is ovulated. The others are discarded. So when we do egg donation, those eggs that the woman is going to discard in that cycle, those are the ones we stimulate and collect from her. So we're not able to go into her egg pool. We don't deplete anybody's egg pool from egg donation. So from a fertility perspective as well, egg donation is safe. But we feel it's really important that people are old enough to think about the implications of egg donation. So as a clinic, we do not recruit egg donors in my clinic under the age of 20. But before anybody goes through the process, they will have counseling, and that will help them to better understand what the implications are and to be able to make an informed decision.
Thanks, Dr. Edi, for such comprehensive response. There's another question in the chat box. Can you express or can you comment on your experience of women having blocked cervix and what are the best options for them?
Sorry, did they say blocked cervix or blocked fallopian tubes?
Well, the person said cervix, but
it's very uncommon to find a woman with a blocked cervix. I have seen a few, but those generally result from use of herbs within the genital tract. So there are some cultures where women are given herbs traditionally, and they put those herbs into the genital tract. And we have seen women develop caustic burns from those eggs, and that can sometimes cause fibrosis, meaning scarring around the cervix, and cause blockage of it. But otherwise, it's extremely uncommon. What we find commonly, what's more common, is blockage within the fallopian tubes. And blockage within the fallopian tubes accounts for about 20% of subfertility, and that generally can result from things like infections, sometimes sexually transmitted infections, chlamydia most commonly, sometimes gonorrhea. They can result from infections from maybe previous surgery. So if anybody who's undergone some pelvic surgery could be at risk of that. Or even things like cesarean sections, if they get infected and complicated, they can result in damage to the fallopian tubes. And other times they can be due to pelvic masses like ovarian cysts, like fibroids. They can cause distortion of fallopian tubes and lead to blockage. But typically, they most commonly will arise from pelvic infections. But there are treatments available. So some of those blocked tubes can be corrected surgically. And where they cannot be corrected surgically, IVF can overcome the problem.
Thank you very much, Doc. Right. So many of you would have seen a survey pop up on your screen. Please make sure you complete that and give us some feedback. Brilliant. We shall continue with the questions. So how does endometriosis differ in management from adenomyosis from a fertility perspective?
That's a really good question. One of the things we know now is that adenomyosis is actually a form of endometriosis. So in essence, they do not differ. Adenomyosis is one of the 5 types of endometriosis. So it just means the presence of endometriotic tissues within the body of the womb itself. The difficulty we have with adenomyosis is unlike other types of where we can surgically go in and cut away the endometriotic tissue and get rid of it. We cannot do that with adenomyosis. And that's because it is within the body of the womb. So what we offer for adenomyosis is medical therapy during the fertility journey. And I'll explain what I mean. So for most people with adenomyosis, the most profound problem it causes is painful and heavy menstruation. And at other times, it is essentially quiet or not problematic. So for those women who have just painful, heavy menstruation, we can put them on medication during periods that will help to control that without actually interfering with their fertility. So that means during their cycle, when they're not on a period, they can keep trying to conceive. When they come on a period, we give them medication to try and control the symptoms of adenomyosis. And a lot of people do well with that. Where that is not feasible or where that is not successful, then our recommendation for those women is that they go through IVF treatment, because with IVF, we can suppress the adenomyosis completely while still being able to carry on with IVF and still get good outcomes.
Thanks a lot, Doc. Yes, just to say, keep your questions coming. The next one, I think you did touch on it, but someone is asking, can a woman have her fallopian tubes blocked but still get pregnant without any treatment?
There are two fallopian tubes. So if you have one blocked and the other one is open, yes, you can still get pregnant. Your chance of pregnancy will be slightly reduced, but you can still get pregnant. So there are women who can fulfill their whole fertility aspirations, have all the children they wish to have with just one fallopian tube. So as long as one fallopian tube is open, that can happen. But if both fallopian tubes are blocked, then you cannot conceive. You either need to have surgery to unblock the fallopian tubes or go through IVF treatments.
Brilliant. Thanks, Doc. And the next question, someone is saying, just a second, see where. Right, I had laparoscopy surgery 2 weeks ago, and I suffer from very heavy periods. They've said I have small fibroid, but they didn't find anything else. So what else can I do?
That's a really difficult question to answer in a forum like this, because it doesn't give me all of the facts, because there are a lot of other things that if I were a gynecologist, I'll want to find out before I'm able to advise further. Having said that, fibroids can cause heavy and painful periods, even small fibroids. So if they haven't found anything else, it could be that the fibroids are the cause, in which case she will need to have a discussion with a gynecologist about going on some treatment for the fibroids. If the problem is only during periods, then she might just need treatment during the periods to manage the heaviness and the increased pain associated with the periods.
Okay, thanks, Doc. I'm going to ask another question, and then I'll bring in Angela, who is one of our partners. Okay. As I mentioned earlier on, the whole month of March is focused on women's health. We're kicking off today on infertility and some of the causes. But then the next week, we're going to look at the cross-cultural and medical approach to managing change during the menopause. Then on the 18th is domestic violence and the impact on emotional well-being. And then we're going to finish off the month of March looking at confident care management for Black skin. So talking about skin, Doc, I have had a private question. Someone is saying since the age of 14, she's always relaxed her hair and wants to understand whether there's any proof or any evidence of using chemicals for the hair and fibroids, because, she seemed quite baffled that, there may be links between chemicals used in her hair and the fibroids she has challenges with.
We've had a lot of those associations, but we really do not have any proven association between hair relaxants and fibroids forming. We think in all populations on Earth, fibroids are common. So across the whole universe, we think that there's a prevalence of fibroids up to about 50%, but that goes up significantly in women from an Afro-Caribbean background. It goes up to maybe about 75% prevalence. So we think no matter where you are born, no matter what race you belong to, if you live long enough as a woman, at some stage, a significant proportion of the female population will develop fibroids. And we think it's a genetic thing. We think it's a genetic thing with some ethnic variations. So we think there's a genetic predisposition, but maybe those genes are more expressed in women from an Afro-Caribbean background. But we're not aware, there are no studies that show that hair relaxants or any other type of diets or anything like that impacts on fibroids forming.
Thanks, Doc. I'll bring in Angela.
Thank you. Thank you for your presentation, Dr. Edmond. It's been really insightful. I have a question, but I'll explain why I'm asking the question. I had endometriosis many years ago, suffered quite a lot with many of the conditions that you described, had difficulty in conceiving, and even when I did conceive, had difficulty in having full-term pregnancies. So unfortunately lost children. As I said, I went through all the pain, all of the stuff you describe. I had multiple laparoscopies. I was fortunate at that time to have private health cover, so got things done very quickly, but suffered for many years before it was actually diagnosed. But when I did have difficulty conceiving, but once I did conceive, and was able to give birth, the endometriosis instantly seemed to go. And to this day, no one's actually explained to me why that would be after suffering for many years, having difficulty conceiving and then having conceived, and then it just kind of disappeared. And I just wanted to know why would that be? Because I've never really had an explanation to that.
That's a really good question, Angela. And thanks for sharing your own story, because I think sometimes it makes it real to a lot of people when it comes from somebody who's been through it, and unbelievable as well. The simple answer to your question is that we don't know. We've had this a lot of time. We just don't know why that's the case. One of the things we do know, however, is that endometriosis has a lot of comorbidities, and those comorbidities include psychological issues. So we know that endometriosis can affect mood. We know that endometriosis can affect stress levels. And on the flip side, we know that stress levels can impact on the perception of endometriosis. So it's like a vicious cycle. So women with endometriosis generally tend to be more stressed than the average population. And women who are more stressed tend to experience the negative pain impacts of endometriosis. And one of the things that people have suggested is that maybe once that fertility aspiration has been achieved, there is a degree of relaxation of those stress levels. And that degree of relaxation of those stress levels have a positive impact on the perception of pain and all the other sensations that come along with it. It's a hypothesis that's put out there, and that's just because one way or the other, we've not been able to prove why exactly what you experience is. We've not been able to prove why that happens, but we know we've heard it from a lot of women.
Okay. Thank you very much, Doctor. I appreciate that.
And thanks, Angela, for sharing your story. For those who are not may not be aware, Angela leads RAFA International Development Agency, which is one of the 6 partners that brings you CATHIP, every Saturday morning, alongside with RCCG, Royals Assembly in Sheffield, Enfield Caribbean Association, Croydon BME Forum, Black Health Initiative, and CAHN. But what we keep saying, and Doc mentioned that, is real. These things are real. So I want to encourage you, spread the word. Health is wealth, knowledge is power, so that we can, together support people in our community. But Doc, going back to Angela's question, Angela, I wonder whether, in hindsight, maybe you would have thought, oh, I should have gotten pregnant earlier, and, or maybe if I'd had, children earlier, then, it would have, reduced the number of years you would have had this challenge. Now, Angela, you're mute.
You're on mute, Angela. You need to unmute yourself.
Yes, it wasn't allowing me to. I was trying.
Sorry.
So the interesting thing is that I had already had one child at the time. So I developed endometriosis after already having one child. And then it took me, so then so by the time I was able to conceive again, there was like a 12-year gap. So it took 12, no, it didn't take 12 years, but I was actively maybe trying for at least 6-7 years and nothing happened. Yeah, so how did I eventually conceive? I had gone through the operations, so I had the laparoscopies, and they did what they needed to do, which then allowed me to conceive. But then even during the pregnancy, I had threatened miscarriages throughout. So I had difficulties right through until I actually gave birth, and after that there were no more issues. But it's interesting what you say about psychological thing, and I'm thinking about it now, because of the trauma that I had experienced in earlier life. There could be a correlation between that, because after I did have my second son, my life seemed to be a lot easier, and yes, there was less stress. I wasn't, so anxious about it. So yeah, that's a possibility. But yeah, so you've pretty much answered. No one ever came back to me and kind of said, oh, well, having a baby cleared everything out or anything like that. So I just wanted to know if there was any kind of medical reason why that would be. So thank you.
Angela, massive thanks once again for sharing your story. And you talked on psychological, mental well-being. I mean, we privilege in CAHN, to have a free counseling service. So please, if these discussions are, touching some raw nerves, please don't suffer in silence. You're not alone. There's a free service. Check the chat box. There's a helpline, or drop us an email, help@CAHN.org.uk, any part of the country, and you would have that free emotional support. But Angela, thanks for bringing this whole discussion to life.
No problem. I do think it's important that, where we can, we share our experiences and make it real for people, because yeah, I mean, it was a long time ago for me, because my child is kind of 31 now. So nevertheless, I still remember the pain that I went through, and I still remember, those unpleasant moments. So yeah, I get it. So thank you.
Yeah, thanks, Angela. Doctor, next question. If a woman has stenosed cervix, not completely closed, catheter transfer failed during IVF procedure, she had transmyometrial transfer, but this also sadly failed. Is there, does it mean all hope is lost in trying, any other assisted means to aid fertility, and I'm sure for this person it's quite emotional, but, your counsel will be helpful.
Yeah, unfortunately, stenocervix is a really difficult medical condition to overcome. And the steps we take generally with a stenocervix are, one, to try and open up the cervix, so to recanalize the cervix. And if we're able to do that, then obviously we'll do IVF the conventional way. If that's not possible, then the only way we can do IVF is by transmyometrial transfer, as she has described. If that's unsuccessful, sadly, we will be recommending that they consider the use of a surrogate, because there are not many other options that are available for us to overcome that difficulty.
Okay, thanks for that, Doc. Whilst you're still on there, someone wants to know the long-term risk of removing fibroids through full hysterectomy.
True.
The long-term risk for someone who's had fibroid but undergoes a full procedure to get them removed.
So did they say hysterectomy or myomectomy?
Yes. Yeah. No. Hysterectomy.
A hysterectomy means that the whole of the womb is removed, so not just the fibroids.
So are there any long-term risk with that?
There are no long-term risks. It's the same risk as having any operation. So just the typical risk of bleeding, infection, blood clots, anesthetic risk, injuries. But once the immediate post-operative course is uncomplicated, then there are no long-term risks to health.
Right, thanks, Doc. We talked earlier on about egg freezing, and someone is asking whether it's free on the NHS. And if it's not free, can you give us some notional indication of the cost involved? Because I think in the African Caribbean community, yeah, people having their own children seem to be the norm. I know that families that have had challenges, you know, when the discussion around fostering and adoption comes up, you know, but someone wants to know the cost implication.
Yeah, that's a really good question. So for egg freezing, whether it's available on the NHS, it depends on the reason for the egg freezing. So what we're discussing here today is what we refer to as social egg freezing. So when you're freezing your eggs just for social reasons, meaning you want to try and preserve your fertility for the future, because you're not at a stage where you're ready to try and conceive. For social egg freezing, unfortunately, the NHS doesn't provide a service. So anybody who wants social egg freezing will need to fund it themselves. And typically, a social egg freezing cycle privately will cost about £5,500 for all the investigations and for the treatment and for the freezing of the eggs, typically. But for people who have maybe cancers or who are going to undergo any surgery that is fertility ending, they can have egg freezing funded on the NHS.
Right, thanks a lot, Doc. But I'm sure it's well worth the investment. So for someone has asked a question about the video, you know, it will remain available on YouTube. And Doc, someone wants a bit more clarification in terms of medication that is non-prescribed. I think you may have alluded to that, you know, contributing to infertility. So if you can touch a bit, you know, if you can unpack that a bit. But then also someone is asking why fibroids seem to be common in the African Caribbean community. Is it a case of genetics? Is it a case of lifestyle? Is it a case of, you know, us, you know, missing some tricks?
I'll start with the fibroid one because that's a simpler one to answer. Fibroids are common in the Afro-Caribbean community simply because of genetics. Fibroids are common everywhere, full stop, but they're even more common in the Afro-Caribbean community simply because of genetics. There's nothing you eat, there's nothing you drink, there's nothing you smoke that will increase your risk of fibroids. It's simply genetics. So, yes, it's down to genetics. And then when it comes to, I think the other question was to do with non-prescription medication. Those are really, really important. I get a lot of people who come to see me, especially from our community, where they've had medication sent to them from relatives in Nigeria, in different African Caribbean communities, where they say, oh, this friend of mine had this problem, this is what they used, we'll send some to you, you use it. if you're trying to conceive, the only medication you should be taking is one that is prescribed to you by your GP for a specific reason. Beyond that, the only thing you should really be taking is maybe the occasional paracetamol or ibuprofen for occasional pain. If you need medication for anything more specific, then that should be prescribed to you by a doctor. We said this for good reason. There are several medications that can interfere with you being able to ovulate, that can impact on the quality of the egg, the endometrium that you develop, and all those are things that can impact on pregnancy. And there are some others that can actually destabilize an early pregnancy implantation site. So it's best to avoid anything that isn't prescribed medically for you when you're trying to conceive. And if you're on any regular medication and you decide to try and conceive, have a discussion with the doctors, let them know what you're planning to do, and they'll review all your medication and make sure everything you're taking is safe in that situation.
Thanks, Doc. Colleagues, we're running out of time, but I'm very keen to field all our questions to Dr. Edi before he leaves. You can tell he's in his clinic, so give us a bit more time, because the answers to some of those questions will help, someone, if not you yourself. Does egg donation affect families? Is it DNA or DNI? I'm not sure, what the abbreviation is. DNI, is that a medical terminology?
I'm sure they'll ask you about DNA.
Right, okay.
So when it comes to gamete donation, so what gamete donation means is that if you take sperm from a man, then the DNA in that sperm comes from the donor. If you take egg from a lady, the DNA in that egg comes from the donor. And that egg and sperm is mixed with the partner of whoever is going to receive that. And then the offspring has a mixture of that DNA. So yes, donated gametes come with their own DNA. That's the simple answer to that question.
Right, thanks, Doc. What happens if the womb is scarred after surgery? And is this likely to impact on fertility? If so, what can be done?
It depends on where the scarring is. So typically, if a woman has a fibroid operation, then you will get scarring in the womb. As long as that scarring does not interfere with the lining of the womb, it is unlikely to impact on the chance of getting pregnant or carrying the pregnancy. It may be that if the womb is scarred in a lot of places because too many fibroids have been removed, then in situations like that, we might recommend that rather than go through labor, a woman has an elective cesarean section to minimize the risk of having traumatic rupture of the uterus in labor. Now, if the endometrium, that's the lining of the womb, is scarred, that's a different issue. That can have direct impact on fertility. That can reduce the chance of getting pregnant. And if a woman gets pregnant in that situation, it can increase the risk of miscarriage. So it really depends on where the scarring is. And that's something that a doctor will be able to ascertain if it's there and be able to offer the right advice. If the lining of the womb is scarred, there are operations that we can do to correct that scarring and to get it back to a normal state.
Thanks, Doc. There's another question here. And also for all listeners, one of our regular ones has suggested a session on egg donation. So maybe Dr. Edi will bring you back on an evening to take us through the journey so we can all learn and allay any fears and myths. But I will
appreciate that, actually, because egg donation is just such an important thing, and there's just such a great need for it that I would appreciate that.
Thank you. Someone is asking, one of our YouTube, participants, should she be concerned about having pelvic pain following her menstrual cycle?
Pelvic pain is not uncommon around period time. So there's some, the periods occur through a sort of inflammatory degeneration of the lining of the womb, and some women can get pain from that. So it's not uncommon. What we do advise is, if you get pain that is stopping you from going about your normal activities. So there's some people, for instance, who have pain, who can't come out of their homes for 2-3 days because they just cannot get out of bed. There's some people who, once their period starts, they're throwing up all the time, you know, from just debilitating pain, nausea, vomiting. Or if you get severe enough pain that you need to take painkillers and painkillers are not impacting on the pain, then do not just assume that these are menstrual pains. You got to think, is endometriosis the cause? Menstrual pains are generally not that severe without any other underlying influence, and they generally will respond to analgesia like paracetamol or ibuprofen. So the message is, any pain that is impacted on your quality of life, your work life, your social life, or not responding to simple analgesia, then you need to find out if there's something else going on like endometriosis.
Brilliant. Thanks, Doc. There have been a couple of questions in the chat box about dietary measures that will reduce the likelihood of fibroids. So for those who are not aware, on Tuesday evenings, we do have a session on, you know, nutrition, and Dr. Hiba and the team can address some of that. But, you know, I'm sure if Dr. Edi has any suggestion, he will, you know, tell us. But Doc, someone is saying you mentioned a number of symptoms caused by endometriosis. Can fibroids also cause similar symptoms, whereas you still don't have endometriosis?
Absolutely. Fibroids and endometriosis, if you remember, one of the first slides I showed was the estrogen dependence. So they're called estrogen-dependent conditions because it's the estrogen, production of estrogen after puberty, that influences the development and the manifestation of both. So the presentations can be pretty similar. So both fibroids and endometriosis can cause cyclical pelvic pain. Both of them can cause heavy periods. Both of them can cause prolonged periods. Both of them can cause irregular menstruation with both premenstrual and postmenstrual bleeding. So some of their presentations, and both of them can cause painful intercourse as well. So yes, they can cause similar symptoms in women.
Yeah, and there's a, thanks, Doc. There's a question in there, if, you know, about whether you offer private consultation. Yes. You know, Dr. Edi works at Alexandra Hospital. So if you get in touch with us, health@CAHN.org.uk, we'll signpost to you. But Dr. Edi, alongside all the colleagues who present on here, if even they don't offer private consultation, are happy to give you independent, impartial second opinion. And that's why we're really grateful for Dr. Edi and other clinicians from the African Caribbean community for, you know, constantly giving their time. Doc, you know, and I mentioned earlier on, 8th of March is International Women's Day. You know, for us at CAHN, you know, and in Greater Manchester, we're looking at the menopause and how we empower women through that. Someone has asked a question saying she's going through the menopause. Would you recommend still having a hysterectomy?
A hysterectomy really has nothing to do with the menopause. There is a specific reason why we offer hysterectomies, and you can have a hysterectomy at any age as a woman if you have got any of those indications. So I would suspect that your doctor has a specific reason for why they have recommended you have a hysterectomy. Now, for some of those reasons, the menopause can actually lead to their amelioration. So if you got maybe adenomyosis or uterine fibroids that have made your doctors recommend a hysterectomy, if you go through the menopause, that can lead to reduction in some of those symptoms. So you might come to a point where you feel a hysterectomy isn't necessary anymore. But a hysterectomy doesn't necessarily stop women experiencing problems from adenomyosis, endometriosis, uterine fibroids. I don't know if that answers the question.
Thanks, Doc, for that. And we will be wrapping up soon, but someone said I had 10-centimeter fibroid and some small ones. I had embolization last February. They said the fibroid is showing signs that it's degenerating. It was also diagnosed, I was also diagnosed with endometriosis. I had admissions removed with the endometriosis in 2014. I've been trying to conceive for 5 years now. What would you advise I do and my next steps?
Unfortunately, a forum like this is not really the place to give that specific advice. I would say you probably need to see a fertility specialist who will be able to go through all of your history and tie everything up for you and be able to give you specific advice. But there are options that are available in any situation. And so it is, as you rightly said, when you undergo embolization, then the fibroids will become degenerated. That is expected. But I think it's difficult for me to be more specific than just that general advice in a forum like this. So I'll strongly recommend that you consider seeing a fertility specialist, because there may be a lot of other things that they need to investigate to be able to give you a more robust opinion about your options.
Great, thanks, Dr. Eddie. And I think, Angela, when you shared your story, and you talked about the private treatment, someone is put in the chat box how they can get the private medical cover. But I'm sure there are many companies out there, and we'll encourage you to check that. We have not had any that we could recommend, only because things vary. Everybody's situation is different. But please, just go on Google, other than that, drop us an email. And I think the final question, Doc, you may have touched on that, but also Angela talked about after her second child, the endometriosis went on its own. And someone is asking, theirs has gone, but, quite concerned about it returning, and what should they do?
That's a really good question. Unfortunately, the nature of endometriosis means that we cannot cure it. There is no cure for endometriosis. So what we do advise is that at the time we diagnose it, we can get rid of the lesions. And what the evidence tells us is even with excision of endometriosis, up to 40% of women will have a recurrence of endometriosis within a 5-year period. And again, it's all down to genetics. So we think that women are genetically predisposed to endometriosis. The stronger your genetic predisposition, the greater the likelihood that you'll have a recurrence. So whenever we treat endometriosis, what we advise women to try and minimize the risk of the endometriosis coming back is to go on some sort of hormonal preparation. So things like the combined oral contraceptive pill, the progesterone contraceptive pill, or even the Mirena intrauterine system, all those have been shown to reduce the likelihood of endometriosis coming back, but there's nothing that can stop it, essentially.
Brilliant. So, Dr. Eddie, massive thanks once again for your time. And to all our listeners, we've had some drop-off, but there are still 84 on the call listening and, engaging with this subject. I suppose for me, the take home is there is help available. There's help out there. And please, you're not on your own. Doc, a couple of people have asked for the slides. I know your PowerPoint is massive in file size, so probably we could PDF them.
I'll find a way to PDF and send it across, yeah.
Brilliant. So massive thanks, everyone, once again for joining us, and spread the word. Next Saturday, we're looking at, the menopause and how, we have a GP who specializes in that. And then the week after, it's going to be on domestic violence. It's in our community, but there's help available, and we need to fully understand its impact on mental health. And then we finish off the year with skin. I know many people like to look smooth and shiny. So please spread the word. all this month is focused on women's health. Let's see you come on with your daughters, with your nieces, with your granddaughters as well, and let's empower ourselves. I'm going to hand over to my colleague, Laurenti, who will give us a couple of announcements. Some may be relevant across other parts. But then also, you know, the thing to remember for those based in London or intending to be in London on the 25th of March, we're going to have a health festival in Enfield, venue to be confirmed. But once again, we're going to work closely with our partners and make sure it's one of fun, but also insightful. Over to you, Laurenti. And Dr. Edi, thank you once again, and also our CATHIP partners for pushing out the messaging.
That's great. Thank you, Charles. Yeah, thank you again, Dr. Edi-Osagie, for a fantastic, fabulous presentation. It's very informative, enlightening as well. So thanks again. And also to Angela from RAFA for sharing your experience. Thank you. And for Charles for being a great host. And thank you to all our attendees on Zoom, Facebook and on YouTube. And you know, if you would like to access today's Health Hour session, you will be able to find it on our YouTube channel along with previous sessions. Also, please do complete the evaluation link. You know, we would love to receive your feedback and your ideas as well. And again, we can put the link in the chat box again for you. And now I would like to share our upcoming events with you. Do pop them in your diary and share them with your family and friends, which would be great. Thank you, Landy, for sharing the slides. So our next CATHIP Health Hour session will take place again next week. So do tune in to benefit from the expertise of our Black doctors. And the topic will be cross-culture and medical approach to managing change during the menopause. And that's Saturday, the 11th of March, same time again, 11 till 12:15. And to register, do email events@CAHN.org.uk. Be great to see you next week. And also, as mentioned by Charles, on a Tuesday we have our healthy arts session, and it's around diet and physical activity, so please do join us, and that's at 6 p.m. to 7:30 p.m. and the topic on Tuesday will be the link between your diet, fibroids and endometriosis, which we discussed today. And there will be a nutritionalist and a registered dietitian, also a physical instructor. And to register, again, please do email events@CAHN.org.uk. And in celebration of our International Women's Day, we invite you to the Empowering Black Woman During Menopause event, and that will be on Wednesday, the 8th of March. So please do join us. It will be a fabulous day. There will be a conference at 2:30 till 4:30 in the afternoon. There'll also be food and stalls between 4:45 and 6 p.m. Also, a celebration of Black womanhood between 6 and 9 p.m. and that's at the Limelight, which is number 1 St Bride Street in Old Trafford, Stretford, Manchester. And you can register or you can book a stall by just contacting us here at CAHN. So it would be great to have you there. And are you a Caribbean of Caribbean or African descent living with diabetes? Well, if you are, you can help shape the way services are provided to support our community by taking part in some conversations. And these are via Zoom. And that's on Tuesday, the 14th of March, from 1 p.m. to 6 p.m. And participants will receive £25 for their time. So to register, please contact research@CAHN.org.uk or drop us give us a ring on 0785 355 6591. That would be great. Thank you. Also, do not forget, as mentioned by Charles today, that during a tough time, you know, you're not alone. Do contact our advocacy or counselling service if you need any support, and that's any support regarding domestic violence, sexual violence, suicide, or if you've got any concerns at all. And our services are available between 9 a.m. and 9 p.m. And you can contact us on 07710 022 382 or email help@CAHN.org.uk. And it's for cultural and religiously appropriate specialist services for by Black professionals. Also, our counselling service is offering a free 10-week adult bereavement support group session, and that's on the 9th of March until the 17th of July. And, you know, again, we offer support, friendship and understanding in a self and confidential space. So to register, please email rosalind@CAHN.org.uk or contact help@CAHN.org.uk, or again, drop us a call on 07710 022 382. And also there is the CAHN Green and Arts Wellbeing Service, which offers a wide range of creative and physical activities inspired by Caribbean and African culture. So you can join us in Stockport every Tuesday, and that's 1 p.m. Or you can come to Bolton every Wednesday, and that's at 2 p.m. And for further information, please email and arts wellbeing @CAHN.org.uk or give us a call on 07789 975 205. And we just also like to mention our CATHIP partners, and do contact a service in your area for further information. So it's CAHN, and then Enfield Caribbean Association, and Rafa International Development Agency, and also the Royal Assembly Redeemed Christian Church of God, and Croydon BME Forum, and the Black Initiative, Black Health Initiative. Okay, that's great. Thank you very much for that. So thanks again to our guest speaker, and also to our host, and to everyone who's joined us today. Do enjoy the rest of your day, do take care, and I will hand you over back to the comms team to close. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@CAHN.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.